Hi, everybody. Welcome back to our peripheral nervous system lecture. And in section 3, we're going to talk about spinal nerves. So here's just a general overview of spinal nerves. We have 31 pairs of spinal nerves, and they consist of 8 pairs of cervical, 12 pairs of thoracic, 5 pairs of lumbar, 5 pairs of sacral, and then 1 pair of coccygeal spinal nerves. And each spinal nerve is going to contain thousands of nerve fibers that are coming directly off of the spinal cord. And the spinal nerves are going to supply all the parts of the body except the head and some neck areas, because remember that the head and some of the other neck areas were supplied by the cranial nerves. So just as a general reminder, all spinal nerves are mixed nerves because they have a dorsal root, so a posterior root that is going to contain the sensory or afferent fibers. And we're going to have ventral roots that contain the motor, the efferent fibers. And those two roots are going to come together, at which point they are going to create a spinal nerve. Okay, so the two roots come together and create our little spinal nerve. And I say little because the spinal nerve itself is actually a very short structure. So here we have in our picture the posterior root, and then we have here our anterior root. Those two roots are going to come together, and when they come together, it's immediately called a spinal nerve. But what happens is that the spinal nerve immediately starts branching off into these other structures. So first we can see our dorsal ramus, which is a very small branch of our spinal nerve. And the dorsal ramus of spinal nerves are going to contain sensory and motor fibers that are going to supply the posterior trunk of the body. Okay, so they go on and they innervate structures on the posterior side of the body. And remember, they contain both sensory and motor fibers because this is a spinal nerve. Our ventral ramus, which is also called the anterior ramus, that's this larger one that you see coming off of here. And this is going to supply the rest of the trunk and then also the limbs, right? So our arms and our legs. And the ventral rami of the spinal nerves are going to form what are called nerve plexes, except in the thoracic region, because in the thoracic region, these are going to form our intercostal nerves that go in between our ribs. In addition, we have a meningeal branch coming directly off the spinal nerve. So that's this little tiny branch that you see coming off of the spinal nerve. And this one actually is going to re-enter the vertebral canal. And it's going to innervate the meninges and also some blood vessels. So remember, the meninges are the pia, arachnoid, and dura mater. So that's what the meningeal branch is doing. And then finally, in certain locations on the spinal column, we have what are called the rami communicantes. And these are the fourth branch that is going to contain autonomic nerve fibers. And these autonomic nerve fibers, they're going to join with the ventral rami only in the thoracic region. Okay, so here is a sympathetic chain ganglion. So this would be sitting just lateral to the body of the vertebra, and it's going to give off these two little rami communicantes, which are joining up with the anterior ramus of the spinal nerve that you can see here. Okay. So the next topic that we will discuss are dermatomes. And dermatomes refer to areas on the skin that are supplied by the sensory fibers that are associated with a single spinal nerve. And all of the spinal nerves, except for C1, participate in dermatomes. And dermatomes are really useful because clinicians can figure out the extent of a spinal cord injury by mapping out the affected dermatomes. So say a person has numbness and tingliness here in their pinky and their ring finger that's radiating up along the medial side of the arm, and perhaps maybe to the posterior inferior shoulder blade. That would indicate to a clinician that the level where the spinal cord is damaged is the C8 spinal nerve, where the C8 spinal nerve exits. So this is a really useful clinical tool to have in your pocket. As an important note here, though, most dermatomes do overlap in areas. So usually if you destroy only one spinal nerve, this will not cause complete numbness of a limb or a region. In general, that tends to be true. So again, dermatomes, they do sensation. So these are the sensory fibers that are associated in the spinal nerve. So remember, the spinal nerve has both sensory and motor fibers, but when we're talking about dermatomes, we're talking about the sensation, the sensory fibers, okay? Myotomes are the other half of the equation. So myotome is referring to the group of muscles that spinal nerve is going to innervate. So this is the thing that's going to account for our motor fibers, because each muscle in the body is going to be supplied by a particular level or a segment of the spinal cord and by the corresponding nerve that goes with that. So here is a list of different structures that are supplied and what level of the spinal cord they're coming out of. So what spinal nerve is associated. So for example, C8 spinal nerve goes on to innervate many muscles in the hands and the fingers. So if there is a loss of motor function in the hands and the fingers, that would point to a damage at C8 spinal cord level. And as a note here, all of the spinal nerves except for C1 and C2 participate in myotomes. So dermatomes, everything except for C1 participated. Myotomes, everything except C1 and C2 participate. So as I mentioned before, spinal nerves go on to form nerve plexes in the body, which can then innervate structures in specific areas. And these nerve plexes are everywhere except for the thoracic region. So we have this cervical plexus, which is sort of the upper cervical spinal nerves. We're going to have the brachial plexus, which is coming off of sort of the lower cervical spinal nerves. We're going to have the lumbar plexus, which is derived from our lumbar spinal nerves. The sacral plexus, which is derived from our sacral spinal nerves. Okay, and so we're going to talk about each of these nerve plexes in more detail. So we're going to go ahead and start then with the cervical nerve plexus. And the cervical nerve plexus is going to include the C2 to C5, which are the first 4 cervical nerves. So cervical nerves C2 to C5. And remember, these plexes, they're coming from the ventral rami, the anterior rami. So we have C2 3, 4, and 5 over here. And these different spinal nerves are going to sort of branch and combine and do different things in different ways. But in terms of their purpose, the sensory fibers that are coming from each of these spinal nerves are going to, in this region, carry information from the skin of the neck, the ear, the back of the head, and the shoulder to the central nervous system. So it's the sensory information coming from those regions to the central nervous system through these spinal nerves. And the motor fibers that are in these same spinal nerves, because remember, spinal nerves have both sensory and motor fibers. The motor fibers that are wrapped up in these spinal nerves go on and to innervate the muscles on the anterior neck. Right, so their function is to allow muscles of the anterior neck to contract and so on. The most important branch of the cervical nerve plexus is this nerve called the phrenic nerve, and so that's the one that you see here. The phrenic nerve supplies both motor and sensory information to the diaphragm. So this is just a general table, and this is really great for studying. But just so you guys are aware, the most important nerve coming from the cervical nerve plexus is this phrenic nerve, and it innervates the diaphragm, does both sensory and motor information between the diaphragm and the central nervous system. So just to kind of put this into perspective and give you like a little clinical connection here, if the phrenic nerve becomes irritated, so here I have isolated the phrenic nerve and you can see it's coming from up in the cervical region and going down and innervating. This is our diaphragm muscle. If this nerve becomes irritated, what can happen is the diaphragm will start to spasm, and this is actually what is known as hiccups. Okay, so that would be the diaphragm spazzing out a little bit. If both of the phrenic nerves become severed, or if the C3 to C5 region of the spinal cord is destroyed, so you have you're in a car accident, you have like a severe neck injury that is like a crush injury that crushes the spinal cord in that region. What can happen is the diaphragm will become paralyzed. And if this happens, respiratory arrest occurs. And so at this point, the victim would require mechanical respirators to stay alive. So a mechanical respirator is a machine that basically forces air into the lungs, and it's like literally breathing for the person. Okay, so this is just about everything about the cervical plexus that you'll need to know. So the next plexus that we'll talk about is the brachial plexus. And the brachial plexus is going to include spinal nerves C5, 6, 7, and 8, and T1. All right, and so this one actually provides virtually all of the nerves that go on to innervate the upper limbs. And there are 4 major groups of branches. So we have roots, which you see in blue, go on to form trunks, which you see in orange. And trunks go on to form divisions, which you see in yellow and in green. And each of these divisions are going to form cords, and each of the cords are going to form different nerves. Okay, so here we see axillary nerve, musculocutaneous nerve, radial, median, and ulnar nerves. And the mnemonic, one of the mnemonics that you can help to remember this, it says really tired, drink coffee. So roots, trunks, divisions, cords is the flow here. And I'm going to give you another one on this slide because I'm going to draw this out for you just to put us, getting us understanding how this particular structure is set up. So The mnemonic here is Roman togas don't cover nipples. All right, so this is going to be roots, trunks, divisions, cords, nerves. So I'm going to draw this out for you guys, and then you can practice drawing this out yourself. It's going to make learning this so much easier for you. Okay, so we're going to start with roots. Right, so we have C5, C6, C7, C8, and T1, okay? And each of these roots are going to form what are called trunks. So actually what happens is C5 and C6 come together. C7 stays on its own, and C8 and T1 roots come together. Okay, so the next structure then along this pathway are the trunks. Okay, so in terms of trunks, they're pretty straightforward. Okay, 3 trunks. And just so we are aware, the trunks have names. So we have the upper trunk, the middle trunk, and the lower trunk. Okay, so the next section, the next segment here are divisions. And so each trunk is going to split into an anterior and a posterior division. Okay, so we're going to start then with the anterior divisions. So the anterior division of the upper trunk and the anterior division of the middle trunk are going to join forces. The anterior division of the lower trunk is going to go its own path. Okay. Let me just make a little key here. So for divisions, this blue is anterior divisions. But we also have posterior divisions. So the upper trunk, the middle trunk, and the lower trunk are going to divide into anterior divisions and into posterior divisions. And the posterior divisions are actually quite simple because the posterior division of the upper trunk, the posterior division of the middle trunk, and the posterior division of the lower trunk are all just going to join forces. Okay, so for our key, pink is posterior divisions. All right, so next comes the chords, and the chords are relatively straightforward. We're going to have, so let me just do this. For the chords, it's pretty simple. Where the anterior division of the upper and the middle trunk came together, we're going to have our lateral chord. Where the 3 posterior divisions came together, this is going to be our posterior cord. And the anterior division from our lower trunk is going to move out that way. And just notice this is not exactly perfect how I want it. So let me fix that. Oh no, okay. Undo. My apologies. Okay. So we have a lateral cord, a posterior cord, and that would make this one the medial cord. All right. And so the next section here is nerves. So each of these cords are going to form specific nerves. So let me do this one in color. I'll do it in blue. Okay. Nerves. All right, so our lateral cord is going to form this nerve, which is called musculocutaneous, which you see here. The lateral cord is also going to branch down this way. And the medial cord is also going to branch this way. Those two are going to form the median nerve, which you see here. Okay, so that will be this guy. Now, I just said that this medial cord, it branched to form the median nerve, but it also has another branch coming off of the medial cord, and this branch goes on and becomes the ulnar nerve. So that leaves just our posterior cord for us to figure out what nerves it becomes, and this one's actually pretty easy. Branches in two ways. It goes on to form the radial nerve and the axillary nerve. So the radial nerve and axillary nerve. Okay, so this is a simple drawing of the brachial nerve plexus. And just to quickly go over it again, we have our roots, C5 through T1. C5 and C6 come together to form the upper trunk. C7 root becomes the middle trunk. C8, T1 roots become the lower trunk. Next, we go into divisions. So the anterior division of the upper trunk and the anterior division of the middle trunk form our lateral cord. The anterior division of the lower trunk forms the medial cord, and the posterior divisions of all three trunks form our posterior cord. From here, our lateral cord is going to branch into the musculocutaneous nerve, and the other branch is going to travel down this way and meet up with one of the branches of the medial cord. Those two are going to come together and form the median nerve. The other branch of the medial cord is going to form the ulnar nerve. And then this posterior cord is going to branch to go on and form both the radial and the axillary nerves. Okay, so this is all the brachial plexus. And again, it's occurring clear up here sort of just after these spinal nerves leave the vertebral canal, the vertebral canal. Okay, as they're coming out, they're forming all of these different structures. Okay, so I would practice drawing this out. It just helps you to understand this a little bit better, I think, in terms of understanding which things go which way. The brachial plexus is definitely the most difficult one to understand. So I just went through several nerves in that last slide of the branching of different nerves and so on. And so there are 5 major branches of the brachial plexus, and so those were the musculocutaneous, median, ulnar, radial, and axillary nerves. And so this is just a summary slide showing you which cords they come from, and then which structures each of those things serves. So I would spend a little bit of time looking at this table before you take your exam. All right, so I'm spending all this time going through the brachial plexus, but why does this matter? Because this matters because injuries to the brachial plexus are very common, and severe injuries can actually either weaken or paralyze the entire upper limb. How do these injuries occur? Well, they can occur if the upper limb is pulled too hard, which would stretch the plexus. For example, when in football, a tackler is going to yank the arm of the running back, that can cause damage to the brachial plexus. Additionally, if there is any kind of major blow to the top of the shoulder, that can actually force the humerus inferiorly, which can actually damage the brachial plexus. And so this is just a cadaver photo of the brachial plexus. And unfortunately, we're not on campus for you guys to see the brachial plexus on our cadaver, but I did actually dissect out the brachial plexus on our cadaver, and it looks exactly like this. So here we see our lateral, posterior, and medial cords. Lateral cord, here's musculocutaneous nerve, and then the other branch of the lateral cord and the median cord coming together to form that median nerve. The posterior cord back there is actually branching in 2 ways. So there's that first branch coming off of it, and you can see that axillary nerve. Here's the second branch coming off of it. You can see the radial nerve. And then you can see the other branch coming off of the medial cord, which going on to form that ulnar nerve. Okay. And then the musculocutaneous coming as the other branch of the lateral cord. So everything that I just went through with you guys, you can actually see on a cadaver very vividly if the brachial plexus is dissected out, which I have done on our on-campus cadaver. So maybe when we get back on campus in the fall, you guys will have an opportunity to look at it. Okay, so clinical connection to brachial plexus. If there is an injury to the median nerve, this would make it very difficult to use what's called pincer grasp. And pincer grasp looks like this. So it's the motion that you do with your fingers, your thumb and your index finger to pick up really small objects. This pincer grasp malfunction or pain is actually seen in carpal tunnel syndrome. And so the median nerve actually travels through a little structure in the wrist called the carpal tunnel. And if there is any kind of overuse injury, say like you type a lot, there can actually be some nerve compression, and that will lead to carpal tunnel syndrome. And carpal tunnel syndrome then would lead to numbness or pain of digits 1, 2, 3, and half of the 4th digit, because all of these areas on the skin are supplied by the median nerve. Median nerve damage is also frequently a casualty of any kind of wrist slashing suicide attempts. All right, so when you slash your wrist, the median nerve tends to be the one that gets affected, which can then result in pain, numbness, tingliness, and loss of function of these areas of the hand. In addition to the median nerve damage, we can also talk about ulnar nerve damage. So the ulnar nerve is actually very vulnerable to injury because of its location. It sits in a little groove on the elbow, and it's not protected by anything except for skin. So severe or chronic damage to the ulnar nerve can lead to sensory loss, paralysis, and muscle atrophy of the areas that are supplied by the ulnar nerve, which includes the pinky and the other half of the fourth digit. Additionally, affected individuals that have ulnar nerve paralysis or ulnar nerve damage might have trouble making a fist. They might have trouble grasping or gripping objects. Additionally, the little fingers and the ring fingers tend to become hyperextended at the knuckles and flexed at the distal IP joints. So the distal IP joints would be here and here. And this would cause the hand to contort into a claw hand, which is what you see here. And this is just if there's any severe damage to the ulnar nerve. Additionally, so I'm sure you guys have all done this before, but striking the what we call funny bone which is the spot where the nerve rests against the medial epicondyle. That is where the funny bone, you're striking the ulnar nerve, and it can make the little finger tingle. And striking the funny bone is never funny, so I'm not sure how it got its name. So the next clinical connection of the brachial plexus I'll discuss is trauma to the radial nerve. If there's trauma to the radial nerve, this will result in what's called wrist drop, which is seen here. It's the inability, you can't extend the hand at the wrist. And this can be caused by things like improper use of crutches, which can compress the radial nerve and impair the nerve's blood supply. And this would cause tingliness, paralysis, wrist drop. There's also a condition called Saturday night paralysis. And this refers to when an intoxicated person will fall asleep with an arm like draped over the back of the chair or a sofa edge. And actually this causes, this cuts off the blood supply to the radial nerve. So people that wake up the next morning, oftentimes they'll be in this wrist drop form and feel like they can't move their hand because they have been compressing their radial nerve all night. So the third plexus that we will talk about, and I promise this one's not quite as complicated, is the lumbar nerve plexus. And actually the sacral and the lumbar plexes overlap so often anatomically that they are together usually called the lumbosacral plexus. So the lumbar plexus includes the ventral rami of L1 to L4 spinal nerves. And the lumbar plexus is actually located within the psoas major muscle, and it's responsible for innervating the abdominal wall muscles and the psoas muscle, also the anterior and the medial thigh. Okay, so lumbar plexus is going to do anterior and medial thigh, and then sacral plexus is going to cover the posterior and lateral thigh. So for the exam, the important branches of the lumbar plexus that should be on your radar include the femoral nerve, which is located here. You can see the femoral nerve. So this is the full structure here. So here's femoral nerve, and then coming off of the spinal nerve, you can see femoral nerve here. But the femoral nerve is the largest terminal nerve, and it actually divides into very large branches. So its motor branches are going to go on and innervate the quads. And its cutaneous branches, which are the sensory branches, they're going to innervate the skin on the anterior thigh and also on the medial surface of the leg, so anterior and inner thigh areas. The other important branch coming off of the lumbar plexus is the obturator nerve, which you see here, and also here. But the obturator nerve itself actually goes on to innervate the adductor muscles. Okay, so this is going to be really important for adducting the leg. So here are all of the branches of the lumbar plexus, and notice I just talked about these first two, but these two are the most important ones, but all of these branches come off of the lumbar plexus. So a clinical connection, why is the lumbar plexus important sort of situation here, is when spinal roots of the lumbar plexus are compressed, we tend to have problems with walking, and gait refers to walking. Other symptoms of lumbar plexus nerve damage include pain or numbness in the anterior thigh. As I mentioned, the femoral nerve, because it supplies the muscles that are responsible for flexing the hip and extending the knee, right? So our quads. Damage of the femoral nerve often is caused by a herniated disc. And so that's what you see here. So here are the vertebrae. This side is anterior, this side is posterior. So here is the spinal cord. And what you can see in between each of the vertebrae, so let me just draw for a second. So here is a vertebra. It's the body of the vertebra. And you can see that in between each vertebra we have, and you guys know this already, that we have intervertebral discs. And normally these intervertebral discs should just stay in between the bodies of each vertebra. However, if there is a herniated disc, basically that means some of the disc has slipped outside of its zone, so really it should have been there, but you can see that has extended beyond its normal area. Now it's actually putting pressure on the spinal cord, which you see here. So you can see it putting pressure up against the spinal cord. In addition, if the obturator nerve is the one that is impaired, then a person would experience pain along the medial thigh. All right, and the last nerve plexus that we'll talk about is the sacral nerve plexus. And so, as I mentioned before, the sacral and the lumbar plexus is overlapped, so oftentimes they're called the lumbosacral plexus. But the sacral plexus actually arises from the ventral rami of L4 to S4. So this is an anterior view. So if this is our sacrum, you can see the anterior sacral foramina, which you guys should know from lab. And that's where the sacral plexus nerves are coming through. The ventral rami of the sacral plexus, or of the sacral spinal nerves, excuse me. So again, sacral plexus is L4 through S4 spinal nerves, ventral rami, and these particular nerves, they're going to come out of the anterior side of the sacrum, but then they're going to pass sort of beneath the coxal bone, right? So even though they're originating from the anterior sacrum, they're actually coming out the posterior side of the body through this pelvic inlet area out to the posterior side of the body, and go on to serve the buttock, the lower limb, some different pelvic structures, and the perineum, which is this lower area here. The most important branch of the sacral plexus is the sciatic nerve, all right? And so you see this huge giant nerve here. This is sciatic nerve, and this is the longest and the thickest nerve in the body, and it actually innervates the hamstrings muscles, the adductor magnus, and most of the muscles in the leg and the foot. And the sciatic nerve actually has two branches. We have the common fibular nerve, which is easy to remember because it goes onto the fibular side of the leg. And then we have the tibial nerve, which is the second branch, which you can see going along the posterior side of the tibia and then turning around and going to the bottom of the foot. So these are the branches, all of the branches of the sacral plexus, but I just mentioned the sciatic nerve as being the most important one, and the two sub-branches of the sciatic nerve being the tibial and the common fibular nerves. So take a look at this table before you take your exam and look at the different structures that are served, especially by the sciatic nerve. So in terms of clinical connections here, sciatica is a very common problem that is going to be characterized by stabbing pain that's going to radiate over the course of the sciatic nerve. So the pain tends to start sort of in this upper buttock area and actually run the entire length of the leg down the back of the legs, this shooting, radiating pain. And some very common causes of sciatica include disc herniation. And this is actually the most common cause, is a herniated disc, which you can see here. I also mentioned that about the lumbar plexus, causing problems with the lumbar plexus. It can also cause problems with the sacral plexus, specifically the sciatic nerve. Another cause of this can be a tight piriformis muscle. So in the buttock, we have a little triangular shaped muscle about right here, give or take approximately. And the sciatic nerve actually, in a lot of people, passes underneath of this piriformis muscle. So if this muscle is tight, it can actually push down on the sciatic nerve, and that can cause sciatica as well. A bad fall could cause sciatica, or a badly placed injection into the buttock can also cause sciatica. So a lot of times if you get an injection into your buttock for any reason, they're actually, most of the time, they're going to place it into sort of this lateral buttock area or this upper like fattier area up here. They try to avoid this region just because the sciatic nerve passes through there. If the nerve is cut, the leg would then become useless and can't be flexed because the hamstrings are the ones that are innervated by the sciatic nerve, so they would become paralyzed. In addition, the foot and the ankle might not be able to move at all, and so the foot is going to drop into plantar flexion, so toes pointed, and this is a condition called foot drop, which I'm going to show you in this video. So I want you to watch the right foot of this patient. So watch this foot here. Right foot. So you'll notice that he's not able to dorsiflex it. Right? He can't pull his toe upwards. It's just kind of sliding. Okay? You just noticed that? Yep. All right, so recovery from sciatic nerve injury, then it's usually very slow and incomplete. So if there are any positive sides, if there's a lesion that is below the knee, usually the thigh muscles remain intact. If the tibial nerve, so if this nerve becomes damaged, then the calf muscles would be paralyzed and you wouldn't be able to plantar flex the foot. And this would lead to a gait that is kind of like a shuffling gait. So you're sort of shuffling your feet because you can't actually plantar flex if it's the calf muscles that are paralyzed. Okay. So here is a summary of the major spinal nerve plexes. So the cervical, brachial, lumbar, and sacral plexus. Here are the ventral rami that are associated with each of those plexes, and then the major nerves coming off of each of those plexes. And that wraps up our section on the spinal nerves. And so I will come back in the last video and talk about reflexes in the reflex arc. Right, so stay tuned for that.